Welcome back to The Deep Dive, the show dedicated to unpacking complex orthopedic topics for mid-senior professionals, giving you that essential shortcut to being truly well-informed. Today, we're plunging into an area often described as the black box of the wrist. Ulnar-sided pain, specifically focusing on impaction syndromes. It's a notoriously challenging area, but a precise understanding of its nuances can profoundly impact patient outcomes. I'm joined by an esteemed expert in this field, and we have a fascinating and detailed exploration ahead of us, aiming to equip you with a sharper understanding for both diagnosis and effective management of these often elusive conditions. So let's unpack this. Before we delve into specific syndromes, could you help us understand the fundamental biomechanics of this intricate area? What are the key players in the distal radial pinner joint, or DRUJ, and how do they work together to facilitate wrist and hand function?
Absolutely. The distal radial nerve joint is a critical, yet often underappreciated, pivot point for forearm rotation. That's pronation and supination, and by extension, overall hand function. It's a compound joint, meaning it's formed by multiple articulating surfaces, primarily the ulnar head interacting with the sigmoid notch of the radius. But the true genius of its design, and what gives it remarkable stability while allowing extensive movement, lies in its soft tissue envelope. The radial nerve ligaments, specifically the dorsal and volar components, are paramount. And then we have the triangular fibrocartilage complex, or TFCC. The TFCC isn't just a simple cushion, it's a multifaceted structure. Think of it as the main suspensory ligament of the carpus, and it plays a truly pivotal role in both stability and efficient load transmission across the wrist.
Right, stability and load transmission seem key here.
Precisely. And what's truly fascinating here, and often a source of clinical confusion, is the dynamic nature of load bearing across this joint. In what we consider an ulnar-neutral wrist, meaning the ulna and radius are of equal length at the wrist joint, the ulnar-carpal joint bears approximately 18% of the axial load crossing the wrist.
Okay, about 18%.
But this isn't a static proportion. The remarkable insight here is how incredibly sensitive this load distribution is to even minute changes in the relative lengths of the ulna and radius, a concept we call ulnar variance. For instance, increasing the ulna's length by just 2.5 millimeters can cause the ulnar-carpal joint to bear up to 42% of the total load.
42% from just 2.5 millimeters. That's a dramatic shift.
It really is. Conversely, shortening the ulna by 2.5 millimeters can reduce this load to as little as 4%. This highlights the profound and sometimes subtle impact of ulnar variance on how forces are distributed within the wrist, fundamentally altering the stress on the TFCC and ulnar-sided carpus.
That shift from 18% to 42% with just 2.5 millimeters is a stark revelation about wrist mechanics. For our listeners who are navigating these complexities daily, what's a subtle yet critical patient presentation or imaging finding that hints at this dynamic ulnar variance being the true underlying issue, even if it's not obvious on a static film? What are the key indicators that we might be missing something on a standard PA X-ray?
That's an excellent question, and it gets right to the heart of the diagnostic challenge. Often, a static PA wrist X-ray, taken with the forearm in neutral rotation, might show what appears to be a neutral ulnar variance, or perhaps even a mildly negative one. Yet the patient experiences profound ulnar-sided pain during specific activities. This is where the concept of dynamic positive ulnar variance becomes critical.
Right, the dynamic aspect.
A key indicator clinically is pain exacerbated by forceful grip, particularly when combined with forearm pronation, think turning a screwdriver or opening a stubborn jar. The patient might report symptoms that don't quite correlate with their initial static radiographs.
So the history is really pointing towards it.
Exactly. For imaging, the pronated grip PA wrist view is absolutely non-negotiable. This specific view, taken with the patient gripping something tightly and the forearm pronated, can reveal a positive ulnar variance that was completely absent on the static film.
Why does that happen?
Why? Because during pronation, the radius effectively shortens relative to the ulna, and forceful grip increases the axial load, forcing that dynamic shift. If you see a previously neutral ulna suddenly appear positively variant on this dynamic view, you found a crucial piece of the puzzle. It tells you that the patient's pain isn't necessarily from a static anatomical anomaly, but from the functional stresses they place on the joint.
That pronated grip view sounds essential then.
Absolutely critical. To expand on that, the TSCC itself is, well, it's critical in this load transfer. Clinical observations and biomechanical studies have shown unequivocally that if the TFCC is excised, for example, due to a severe irreparable injury, the load transmitted to the ulna can decrease by as much as 67%.
67%. That's a massive reduction.
It is, with the ulna then bearing only around 6% of the total wrist load. This dramatic reduction underscores its role as a primary load bearer and cushion. Moreover, it's not just static anatomy. As I mentioned, forearm pronation and forceful grip activities can induce a dynamic positive ulnar variance, meaning the ulna effectively lengthens, even in wrists that are initially ulnar neutral or even ulnar negative. This dynamic change can significantly increase the ulnocarpal load, contributing to the development of pathological conditions over time. It's a subtle but powerful biomechanical phenomena that often goes overlooked.
That 67% load decrease with TFCC excision is astonishing. It really underscores its role. But does this then imply that in cases of severe, irreparable TFCC damage, simply excising it could, in some cases, offer a more immediate and less invasive solution than an osteotomy, even with the subsequent load shift? What are the clinical trade-offs there, especially in terms of long-term stability versus immediate symptom relief?
That's a perceptive question, and it's on a real clinical dilemma.
Yeah.
While excising an irreparable TFCC can indeed provide immediate pain relief by unloading the ulna, it comes with significant trade-offs regarding long-term stability of the distal radial ulnar joint.
Ah, the stability issue.
Precisely. The TFCC, particularly its peripheral attachments, is crucial for DRUJ stability. If you excise it entirely, you risk creating persistent instability, painful clicking, or even chronic subluxation of the ulna relative to the radius. This instability can then lead to secondary osteoarthritis of the DRUJ down the line. So, whilst it might offer a quick fix for pain, it compromises the long-term mechanics and integrity of the joint.
So it's potentially trading short-term gain for long-term problems.
Potentially, yes. An ulnar shortening osteotomy, by contrast, not only reduces ulnar-sided load, but also helps to tension and stabilize the ulnocarpal ligament complex and often the DRUJ itself. This provides a more biomechanically sound and durable solution, albeit with a more involved recovery. The decision really hinges on balancing immediate symptomatic relief against preserving long-term joint function and stability. It's rarely a straightforward choice and often involves a detailed discussion with the patient about these very trade-offs.
That makes perfect sense. So with this foundational understanding of biomechanics and the dynamic interplay of forces, how do these subtle stresses and load shifts then translate into the common pathological conditions we encounter, specifically the impaction syndromes we're discussing today?
Well, the principles of load transmission and ulnar variance are directly applicable. When the ulnar side of the wrist is subjected to chronic, excessive loading, particularly due to a positive ulnar variance, whether static or dynamic, the anatomical structures involved in load bearing begin to degenerate. Think of it like a tire that's constantly running overinflated or out of alignment. Eventually, it wears out prematurely. This sets the stage for what we commonly refer to as impaction syndromes. It's essentially a mechanical breakdown from repeated stress and abnormal force distribution.
Okay, so it's a wear and tear process driven by mechanics. Let's start with the most prevalent, ulnar impaction syndrome. From what we understand, it's typically a degenerative condition resulting from excessive load across the ulnar carpal joint. Can you elaborate on its pathophysiology, particularly its association with ulnar variance?
Ulnar impaction syndrome, or ulnocarpal abutment, is indeed the most common cause of chronic ulnar-sided wrist pain, and it is fundamentally a degenerative process. It's usually linked to a relatively long ulna, which we refer to as positive ulnar variance.
Which can be congenital or acquired, you mentioned.
Exactly. It could be congenital, and the individual is simply born with a longer ulna, or it can be acquired. Common acquired causes include a malunited distal radius fracture, where the radius heals in a shortened position, effectively lengthening the ulna relative to it. Another cause can be following a radial head excision, which similarly alters the relative lengths of the forearm bones, shifting more load distally to the ulna.
Right, changing the whole forearm linkage.
Precisely. The excessive loading due to this positive variance leads to a spectrum of pathological changes within the ulnocarpal joint. The TFCC, being the primary cushion and stabilizer, is often the first to show signs. We frequently observe degenerative perforations within its central or ulnar portions, and often a generalized fraying of its substance. There's also fraying or tearing of the lunar-tricutril interosseous ligament, which is a crucial stabilizer between the lunate and tricking bones.
So multiple structures start to break down.
Yes, and furthermore, we see chondral wear on the articular surfaces of the lunate, triquetrum, and the ulnar head, essentially. The smooth protective cartilage layers begin to fray, thin, and erode, leading to painful bone-on-bone friction. Another contributing factor that can exacerbate this excessive ulnocarpal load is an increased dorsal tilt of the radius, often seen in malunited distal radius fracture injuries, which shifts more of the axial load to the ulnar side of the wrist. This highlights how various anatomical factors can converge to create the ideal conditions for chronic impaction.
So, given these pathological changes, what are the characteristic clinical presentations that clinicians should be looking for, and what diagnostic tools are most effective in confirming the syndrome?
Patients with ulnar impaction syndrome typically present with insidious progressive ulnar-sided wrist pain. This pain is almost universally exacerbated by activities involving forceful grip, forearm pronation, and ulnar deviation of the wrist.
That combination again, grip, pronation, ulnar deviation.
Yes, it's a classic triad. They might describe it as a deep aching pain or sometimes a sharp catching sensation. On physical examination, you'll usually find localized tenderness dorsally, situated just distal to the ulnar head, and ulnarly, just volar at the ulnar styloid process, particularly over the fovea. A limited range of wrist motion due to pain, especially at the extremes of pronation, supination, and ulnar deviation, is also a common finding, particularly in more advanced cases where degenerative changes have progressed.
And what about specific tests?
A key clinical test to evaluate for ulnar impaction is the ulnocarpal stress test. To perform this, the wrist is placed in maximum ulnar deviation, axially loaded, and then passively rotated through the full range from supination to pronation. Reproduction of the patient's typical ulnar-sided pain during this maneuver is highly suggestive of ulnar impaction.
Okay, the ulnocarpal stress test. Any others?
Other provocative tests that can be useful include the fovea sign, where direct palpation of the fovea reproduces pain, indicating potential TFCC injury or inflammation. The TFCC stress test, which involves flexion and extension of a maximally ulnarly deviated wrist, and the pisiform boost test, which involves volar translation of the ulna with pronation supination to assess DRUJ stability.
But these aren't completely specific, are they?
No, and that's critically important for clinicians to remember. These tests can also be positive in other conditions causing ulnar-sided pain, such as isolated TFCC injury or lunotriquetral ligament injury. So they must be interpreted in conjunction with the full clinical picture. The art is in differentiating the primary culprit.
Right, putting all the pieces together. What about imaging confirmation?
For definitive diagnosis, initial imaging typically involves posterior-anterior or PA wrist radiographs. These should ideally be taken in a neutral rotation to accurately assess static ulnar variance. Crucially, as we discussed, a pronated grip PA view is also essential, as it can reveal dynamic positive ulnar variance, which might not be apparent on a static film.
That dynamic view again.
Absolutely. These radiographs may show characteristic signs of chronic impaction, such as subchondral sclerosis, which is increased bone density just beneath the cartilage, or cystic changes in the affected bones, that is, the ulnar head, lunate, or triquetrum, indicating areas of bone stress and degeneration. In severe or chronic cases, you might even see signs of frank degenerative arthritis at the ulnocarpal joint with significant joint space narrowing.
And if the x-rays are unclear?
When the diagnosis remains unclear, or if there's suspicion of complex soft tissue involvement, magnetic resonance imaging, or MRI, is invaluable. MRI can detect early cartilage fibrillation and chondromalacia, which are subtle signs of early degeneration even before radiographic changes are evident. It can also identify bone marrow edema or hyperamia, which are indirect signs of the mechanical stress and inflammation. Furthermore, MRI is excellent for assessing the integrity of the TFCC and the lunotriquetral interosseous ligament, helping to differentiate from other pathologies.
And you mentioned the Palmer classification.
Yes, the Palmer classification of TFCC lesions, particularly the Class II degenerative lesions, IIA through NACE, provides a useful framework for understanding the spectrum of pathology associated with ulnar impaction syndrome. It helps categorize tiers based on location and the degree of associated degeneration and chondromalacia, which directly guide surgical planning.
Okay, that's very clear. Once diagnosed, what are the established treatment pathways, both conservative and surgical, and what are the critical considerations clinicians need to weigh when choosing the right approach for their patients?
Initial management for idiopathic ulnar impaction syndrome is almost always conservative, especially if symptoms are mild or recent in onset, or if imaging shows only early degenerative changes. This typically involves a dedicated period of 6 to 12 weeks of rest or immobilization, often with a customized wrist splint to limit aggravating movements. This is paired with strict activity modification avoiding those key movements: forceful gripping, repetitive twisting, or ulnar deviation.
Avoiding the triggers.
Exactly. Non-steroidal anti-inflammatory drugs, or NSAIDs, are commonly prescribed to manage pain and inflammation, sometimes for extended periods. In some cases, local corticosteroid injections, carefully placed into the ulnocarpal joint, can be offered to provide temporary symptomatic relief by reducing inflammation, helping to break the pain cycle.
How successful is conservative management typically?
Well, it varies. It's worth noting that specific guidelines on the optimal duration of conservative treatment are somewhat limited. Clinical studies indicate that a significant proportion of patients, perhaps as high as 25%, may ultimately require surgical intervention due to persistent and debilitating symptoms, despite a thorough course of non-operative care.
A quarter needing surgery eventually. Are there predictors for who might fail conservative treatment?
Yes, some factors have been associated with a higher likelihood of conservative treatment failure. These include female gender, a longer duration of symptoms before presentation, high reported pain scores, and evidence of MRI enhancement suggesting active inflammation and more advanced pathology. It's often a signal that the mechanical issue needs a more definitive mechanical solution.
Right, so when non-operative measures fail, surgery becomes the focus. What's the goal there?
When non-operative measures fail to provide adequate relief, surgical intervention is considered. The primary goal of surgery is to decrease the relative length of the ulna, thereby reducing the excessive load across the ulnocarpal joint and alleviating the impingement. There are two main surgical options widely employed: the ulnar shortening osteotomy and the wafer procedure.
Let's start with the ulnar shortening osteotomy, often called the gold standard.
Yes, the ulnar shortening osteotomy, first described by Milch back in 1941, is often regarded as the gold standard for treating ulnar impaction syndrome, especially when a significant positive ulnar variance is present. This procedure involves removing an appropriately sized segment of the ulna, typically from the diaphyseal region at the junction of the distal and middle third. The shortened bone is then fixed with a stable plate and screws to allow for bony union, typically taking 6 to 8 weeks for consolidation.
And how much you shorten it?
The exact amount of shortening needed is precisely calculated from preoperative pronated grip PA wrist radiographs, with the aim of achieving a 0 to -1 millimeter of ulnar variance, slightly negative ideally.
What are the advantages of this approach?
This technique offers several distinct advantages. It provides a precise and controlled reduction in ulnar length. It helps to stabilize the ulnocarpal ligament complex by tensioning the ulnar side, and crucially, it avoids damaging the distal ulnar articular surface, preserving the joint itself. It's particularly advantageous when more than 2–3 millimeters of shortening is required, or if there's concomitant dorsal subluxation of the ulna, or a significant lunotriquetral ligament injury that needs addressing, as the shortening can help reduce stress on these structures. Patients typically experience good and predictable results with this procedure, reporting significant improvements in pain relief, increased range of motion, and enhanced grip strength in the long term.
But it's not without its downsides, is it? You mentioned potential complications earlier. A 30% complication rate for the gold standard is significant.
That's a critical point to address. And you're right, a 30% overall complication rate, though often including minor issues, warrants attention. The most common issues include delayed union or non-union of the osteotomy site, which occurs in perhaps 5–11% of cases. This risk can be exacerbated by factors like smoking or diabetes.
What else?
Hardware irritation requiring removal is also quite frequent, affecting somewhere between 18 and 39% of patients in various series. The plate can sometimes be prominent under the skin.
That's a fairly high rate for hardware removal?
It is. It's also important to note that ulnar shortening, whilst relieving ulnocarpal pressure, can potentially increase peak pressure at the distal radioulnar joint, the DRUJ. This suggests that only the minimum required shortening should be performed to avoid creating a new problem.
So over-shortening can be an issue.
Yeah.
Are there contraindications?
Yes, it should ideally be avoided in patients with significant pre-existing symptomatic DRUJ arthritis, or in those with what's called a reverse oblique DRUJ slope, where the radius's sigmoid notch articulates in a way that shortening the ulna could paradoxically increase compression on the ulna, especially with pronation, worsening DRUJ symptoms.
So patient selection is absolutely key.
Absolutely paramount. Understanding the precise etiology of the pain and the state of the DRUJ is crucial. Often, wrist arthroscopy is performed concurrently with the osteotomy to directly visualize and address any associated TFCC perforations or tears and to debride articular cartilage fibrillation, ensuring a comprehensive treatment.
What about the wafer procedure? How does that compare?
The wafer procedure, alternatively, involves the partial resection of 2 to 4 millimeters of the distal dome of the ulnar head. Crucially, it aims to preserve the ulnar styloid process and its associated ligamentous attachments, particularly the critical foveal and superficial fibers of the TFCC. This procedure can be performed either openly or arthroscopically, with the arthroscopic approach gaining popularity due to its minimally invasive nature.
What are the main benefits of the wafer?
Its main advantage lies in the absence of hardware-related complications, which we just discussed with the osteotomy, and a significantly lower risk of delayed union or non-union. Clinical outcomes in terms of pain relief and wrist functional status are often comparable to those achieved with ulnar shortening osteotomy, particularly for patients with mild to moderate impaction, needing less than, say, 3 or 4 millimeters of relative shortening.
But it has limitations too.
Yes, a significant limitation is that the wafer procedure is restricted to a maximum of about 2, 3, maybe 4 millimeters of effective shortening. It also doesn't effectively address stylocarpal impaction, where the ulnar styloid itself is impinging on the triquetrum, nor does it improve dorsal subluxation of the ulna or actively tension the ulnocarpal ligamentous complex, which an osteotomy can achieve.
So it's better for less severe cases, perhaps without instability?
Generally, yes. Some surgeons might even elect to resect the central articular disc of the TFCC arthroscopically to unload the joint, even without a perforation, believing this is sufficient in select cases. But that's a slightly different approach again.
And you mentioned a third option, the distal metaphyseal osteotomy.
Yes, that's an alternative approach that has gained some interest, particularly for preserving the DRUJ. This is a closing wedge osteotomy performed more proximally, in the metaphysis, just proximal to the sigmoid notch of the radius. The key advantage here is that it preserves the articular cartilage and ligamentous structures around the ulnar head, including the TFCC foveal attachment. By performing the osteotomy proximal to the DRUJ, it potentially avoids issues like continuous bleeding, sometimes seen in wafer resections, and the common hardware problems or delayed union associated with standard diaphyseal ulnar shortening osteotomies.
Sounds promising, but less common.
It is less common, technically quite demanding, and frankly, further studies with larger patient cohorts are needed to establish its full efficacy and long-term outcomes, particularly regarding its impact on DRUJ mechanics. Overall, the choice between these procedures, USO, wafer, or metaphyseal osteotomy, is highly individualized. It depends on the specific anatomy, the degree of ulnar variance, the presence of associated pathologies like DRUJ arthritis or severe ligamentous laxity, and patient factors such as activity level and comorbidities.
That was an incredibly thorough deep dive into ulnar impaction syndrome, the most frequent culprit. But as you alluded earlier, the ulnar side of the wrist is often called a black box for a reason. It hides a number of other distinct impaction syndromes that can mimic its symptoms. How do we ensure we're differentiating these, and what are some of those important, albeit rarer, conditions we need to consider?
Indeed, the differential diagnosis for ulnar-sided wrist pain is extensive. Whilst ulnar impaction syndrome is certainly the most common, it's vital to distinguish it from other impaction syndromes that may present similarly but require different diagnostic and therapeutic approaches. As I often tell my residents, the wrist isn't just a joint, it's a miniature ecosystem, and the ulnar side is its densest jungle. You really need to know your flora and fauna to pinpoint the source of the problem.
A dense jungle, I like that analogy.
These other conditions include hematarthrosis, lunotriquetral ligament tears, or HL disease, triquetrohumed impaction syndrome, or this, and ulnar styloid impaction syndrome, or USS. Each has its own unique pathophysiology, characteristic findings, and specific management considerations.
Okay, let's explore those. Start with Haeckel disease.
Right, let's begin with hematarthrosis, lunar-triquetral ligament tears, or Haeckel disease. This represents another distinct impaction syndrome. This condition involves degenerative changes primarily affecting the hamate bone, where it articulates in the midcarpal joint, and it is frequently associated with tears of the lunar-triquetral ligament. It seems to be more commonly observed in men and individuals engaged in repetitive wrist motions or heavy manual labor, suggesting a significant mechanical overload component in its etiology, often from forceful wrist extension and ulnar deviation activities.
And what's the specific mechanism here?
What's really fascinating about ARL disease from a pathological perspective is how frequently we see it connected to specific anatomical variations in the lunate bone. We recognize two main types of lunate morphology. Typolunates have no separate facet articulating with the hamate. This morphology is seen at about 53% of wrists. However, type 2 lunates, found in around 47% of individuals, possess an additional medial facet that articulates directly with the hamate, in addition to its articulation with the capitate.
So nearly half have this type 2 lunate.
Yes, and research indicates a clear association between this type 2 lunate morphology and the development of proximal hematarthrosis, especially when the wrist is positioned in ulnar deviation. This direct, often excessive contact between the type 2 lunate and the hamate predisposes the joint surfaces to premature degenerative changes over time. The associated lunotriquetral ligament tears are thought to arise from the repetitive shear stress and potential instability caused by this abnormal impaction, leading to a cascade of degenerative changes.
How do we diagnose ALIT?
Diagnostically, type 2 lunate morphology might sometimes be identified on standard wrist radiographs, though its presence alone isn't diagnostic of symptoms. MRI is invaluable here, as it can reveal specific signs such as subchondral edema bone bruising at the proximal pole of the hamate and signs of lunotriquetral ligament injury, both of which are highly suggestive of an axial adhesion. However, wrist arthroscopy remains the gold standard for definitively identifying and confirming hamate arthrosis and for precisely staging any associated lunotriquetral ligament lesions. It allows for direct visualization of the articular surfaces and ligamentous integrity and enables intraoperative assessment of carpal stability.
And treatment for HELT, does it follow a similar pattern?
Treatment typically begins with conservative measures, similar to other impaction syndromes. This involves strategies such as splinting, local corticosteroid injections to reduce inflammation, and strict activity modifications to reduce aggravating stresses on the joint. Unfortunately, the literature provides limited specific guidelines on the precise duration of conservative treatment before considering surgical intervention. But typically, a 6-12-week trial is attempted.
And if that fails?
For those patients who fail to achieve satisfactory relief with conservative treatment, surgical intervention is often indicated. This usually involves arthroscopic or open resection of the proximal pole of the hamate, effectively creating space and eliminating the impinging contact. Clinical studies have shown excellent clinical outcomes with sustained relief after an average of 2.2 to 2.4 millimeters of resection of the proximal hamate pole. Quite a precise amount of bone removal.
What about the associated ligament tears?
That's crucial. Concomitant lunotriquetral ligament injuries, which are frequently present and can contribute to ongoing pain and instability, are managed based on the degree of instability identified during arthroscopy. This might involve various procedures such as pinning the joint temporarily with K-wires, debridement of the torn ligament edges, capsulodesis, where a portion of the joint capsule is tightened, radiofrequency thermal shrinkage, or in more severe cases with tronic instability, even arthrodesis, which is the surgical fusion of the joint. Arthrodesis stabilizes it at the cost of motion and is typically reserved for severe, intractable instability or pain.
What's the typical outcome after surgery?
The majority of patients who undergo surgical treatment for HL disease report excellent results, with no pain or only mild discomfort post-operatively, allowing them to return to their previous activity levels without significant limitation.
That's a comprehensive look at a pill. Moving on to another intriguing, albeit rarer condition, trichotrahema impaction syndrome. How does this present, and how is it differentiated from the other syndromes we've discussed, especially when its presentation can be so subtle?
Trichotrahema impaction syndrome, or THIS, is indeed a less frequently reported but undoubtedly significant cause of ulnar-sided wrist pain. It occurs when the trichotrom and hamate bones impinge upon one another, usually during specific wrist motions that exceed the normal physiological range, often involving forceful ulnar deviation and extension. Due to its subtle nature and occasional overlap with other conditions, it can be particularly challenging to diagnose and often requires a high index of suspicion.
Where exactly do patients feel the pain?
Patients typically report localized pain, specifically over the dorso-ulnar aspect of the wrist. This pain is often felt roughly 1 to 2 centimeters distal to the TSCC complex, or approximately midway between the base of the small finger metacarpal and the ulnar styloid, a very specific point. A classic presentation is its association with two-handed sports, such as golf or baseball, with symptoms predominantly experienced in the lead, non-dominant hand at the critical point of impact with the ball, where maximal ulnar deviation and axial load occur.
So there's often activity-specific link to impact.
Yes, that's a key differentiator. They might describe a sharp, stabbing pain or sometimes a clunking sensation during the aggravating activity.
How is this diagnosed? Radiographs often normal initially.
That's right. Standard wrist radiographs may initially appear unremarkable in early cases, which can contribute to diagnostic delay. However, in more advanced or chronic cases, radiographs can sometimes show subtle signs of joint space narrowing, osteophyte formation, small bone spurs, or even loose bodies at the triquetrohamate articulation. It is absolutely crucial to include clenched fist PA views to rule out any underlying ulnar positive variants and potential coexisting ulnar impaction syndrome, as these can be compounding factors or primary differentials.
Does MRI help here?
Magnetic resonance imaging, or MRI, can be more revealing, as it may show intraosseous edema in the impinging bones, chondral damage to the articular surfaces indicating cartilage loss and synovitis or inflammation within the joint. Interestingly, bone scintigraphy has been shown to demonstrate increased uptake in the triatriomet region in some specific cases, indicating increased metabolic activity or inflammation.
What about diagnostic injections?
A diagnostic corticosteroid injection directly into this specific articulation can be highly effective, not only for confirming the diagnosis by transiently alleviating pain, but also for providing immediate therapeutic relief. It's a powerful tool for isolating the pain source.
And arthroscopy.
As with other Impaction syndromes, midcarpal arthroscopy offers direct visualization of the joint, allowing for definitive confirmation of impingement, assessment of cartilage fibrillation, and identification of exposed cancellous bone, which are all hallmarks of the syndrome. It gives us the clearest picture.
How is this treated? Similar pathway.
Yes, treatment for this also follows a conservative to operative pathway. Non-operative management includes essential activity modifications to avoid aggravating movements, splint immobilization to rest the joint, anti-inflammatory medications to reduce pain and inflammation, and, as mentioned, corticosteroid injections.
How often does conservative care work?
Clinical series have demonstrated that approximately 50% of patients can achieve satisfactory outcomes with conservative care alone, with some even returning to their pre-injury activities with or without minor limitations. So a significant subset responds well to non-surgical approaches.
And for the other 50%?
For those who do not respond adequately to conservative measures, surgical intervention is considered. This is often performed arthroscopically and typically involves synovectomy to remove inflamed tissue, microfracture to stimulate cartilage repair in areas of chondral loss, or partial excision of any hypertrophic hamate or trichotrom bone that is causing the impingement. The primary aim of the surgical debridement is to prevent direct bone-on-bone impingement during ulnar deviation and other forceful wrist movements, restoring a smoother articulation.
And the outcomes of surgery for this?
This arthroscopic approach has shown excellent results in clinical series, with a high proportion of patients returning to full activity without pain and with minimal surgical insult, highlighting its effectiveness and relatively low morbidity compared to open procedures.
Okay, that covers this. Finally, let's talk about ulnar-styloid impaction syndrome. How is this distinct from the general ulnar impaction syndrome?
Right. Ulnar-Sided Impaction syndrome, or USS, is distinct because it specifically refers to painful contact between the tip of an excessively long ulnar styloid process and the trichotrom bone in the wrist. While the ulnar styloid is a normal anatomical feature, typically measuring between 2 to 6 millimeters in length, an overly long one can cause significant problems due to direct mechanical impingement during wrist movements, particularly ulnar deviation. It's purely about the styloid hitting the carpus.
Is this common? And any demographic links?
It is recognized as a common cause of ulnar-sided wrist pain and is reportedly more prevalent in Asian populations, which is attributed to a higher incidence of naturally positive ulnar variants and proportionally longer styloids in these demographics. The underlying pathology involves the elongated styloid tip directly impinging on the trichotrom, leading to inflammation, localized swelling, and even bone bruising and edema, which can be seen on MRI.
What happens if it's left untreated?
Chronic pressure from this impingement can subsequently lead to degenerative tears in the TFCC, particularly its distal attachments near the styloid, and uneven wear of the articular surfaces of both the styloid and the trichotrom. If left untreated, this progressive impaction can ultimately lead to wrist instability, breakdown of important ligaments, particularly the trichotrollinate ligament, and even subluxation or full dislocation of wrist bones. This results in significant disability, chronic pain, decreased wrist motion, and a substantial loss of hand function over time. It's not just about the styloid, it's about its impact on the wider carpal mechanics.
How do patients typically present clinically?
Clinically, patients present with characteristic ulnar-sided wrist pain, which is often exacerbated by forearm pronation, ulnar deviation, or forceful group activities. On examination, there's usually specific tenderness directly along the ulnar styloid process itself, distinct from the tenderness found more centrally over the fovea in TSCC issues or general ulnar impaction.
And diagnosis, primarily radiographic.
Diagnosis is primarily made with postero-anterior, or PA, wrist radiographs, which are used to assess the overall ulnar variance and, critically, the absolute length of the styloid process. These radiographs may also reveal characteristic signs such as subchondral sclerosis or cyst formation at the impinging styloid tip or trichotrom. Pronated grip views are also important for dynamic assessment, as they can show the change in relationship between the styloid and trichotrom during functional movements.
Does MRI add much here?
While MRI can certainly help evaluate associated soft tissue damage, such as TFCC tears and lunar tricutural ligament integrity, it's the clinical presentation in conjunction with clear radiographic evidence of a prolonged styloid that primarily guides the initial suspicion and diagnosis.
Treatment strategy for USIS, conservative first.
Yes, treatment for ulnar styloid impaction syndrome also begins conservatively, similar to the others. This involves a minimum period of 6 to 12 weeks of rest, non-steroidal anti-inflammatory drugs, local steroid injections into the specific articulation or around the styloid, and strict activity modifications to avoid aggravating movements. And if conservative measures fail, what are the surgical options?
If these conservative measures are unsuccessful in alleviating symptoms, surgical options are then considered. One approach, particularly if there's coexisting ulnar-carpal impaction due to overall positive ulnar variance, is an ulnar shortening osteotomy. This effectively addresses both the styloid length relative to the radius and the broader ulnar impaction.
But what if it's just the styloid that's the problem?
For isolated ulnar styloid impaction, a more specific procedure is often preferred. The partial ulnar styloidectomy, sometimes referred to as a wafer procedure of the styloid. This involves surgically excising only the distal 2 to 4 millimeters of the ulnar styloid process. Crucially, meticulous care must be taken to preserve the critical associated ligamentous attachments, particularly the radial ligaments that originate from its base, as these are vital for DRUJ stability. If these are compromised, it can lead to iatrogenic instability.
I see. And you mentioned another technique, the oblique osteotomy.
Yes, a more specific and increasingly favored procedure, especially for maintaining DRUJ stability, is the oblique ulnar styloid osteotomy. This involves removing a precisely measured, wedge-shaped piece of bone from the side of the styloid at an angle, effectively shortening it whilst preserving the main shaft and its attachments.
What's the key advantage there?
This technique has a significant advantage. It preserves the vast majority of the soft tissue attachments to the styloid, particularly the critical foveal attachments of the TFCC and the ulnocarpal ligaments. By maintaining these ligamentous origins and insertions, it thereby preserves the inherent stability of the distal radial ulnar joint. This is a unique and important feature compared to a simple distal styloidectomy, where soft tissue attachments might be more easily compromised.
And the results?
Early clinical series utilizing this oblique osteotomy have shown very encouraging results, with a high percentage of patients returning to their pre-injury activity levels, experiencing significant pain relief, and reporting high satisfaction rates. However, careful patient selection is paramount to ensure the diagnosis is accurate and that there isn't significant pre-existing DRUJ ligamentous instability, as this procedure relies on intact soft tissue attachments for its success and optimal outcome.
That's a fascinating distinction between the styloidectomy and the oblique osteotomy, highlighting how precision can make a real difference to long-term stability. So when you talk about practical rehabilitative strategies for all these conditions, both conservatively and post-operatively, what practical advice can you offer our listeners regarding physiotherapy and strengthening protocols?
Rehabilitation is absolutely fundamental, you're right, both for conservative management and as a crucial component of post-operative recovery for all these impaction syndromes. The overarching principle is intelligent activity modification. Patients must learn to avoid activities that aggravate their symptoms. This commonly includes movements like push-ups, forceful gripping, any excessive repetitive twisting, and deep ulnar deviation of the wrist. Pain should always serve as the patient's guide. If an activity causes pain, it should be avoided or modified. It's about respecting the wrist's current limitations while working to restore its capacity.
What does the initial phase look like?
Initial conservative management, or the early post-operative phase, often involves splinting or immobilization. For example, certain TFCC tears, which are frequently associated with impaction syndromes, may require at least 4 weeks of consistent splint wear to allow for initial healing and reduce mechanical stress. Once the sharp, acute pain subsides, typically under the close guidance of a physiotherapist, specific stretching exercises are carefully introduced. These include a full range of wrist motion exercises, flexion, extension, and side-to-side movements, radial and ulnar deviation, holding each position gently for about 5 seconds.
Gentle stretches first.
Yes, gentle. Comprehensive wrist stretches, where the back of the hand is pressed to gently bend the wrist or the fingers are pressed backward, are also crucial, holding for maybe 15-30 seconds with a straight arm to restore flexibility. Forearm pronation and supination exercises, performed with the elbow bent at 90 degrees and kept close to the side, are vital for restoring full rotational mobility of the forearm, often limited by pain or stiffness.
And when does strengthening begin?
As stretching becomes nearly painless, strengthening exercises are gradually introduced, progressively increasing resistance. Simple exercises like wrist flexion and extension, holding a light object such as a soup can, or perhaps light dumbbell or hammer handle with the palm up or down, help build the endurance and strength of the forearm musculature. Grip strengthening using a soft rubber ball or gradually progressing hand grippers is also highly beneficial for improving overall hand and wrist function, which is often compromised in these conditions.
Are there specific exercises for the ulnar side stability?
Yes, beyond these traditional exercises, there's a particular emphasis on exercises that target specific forearm musculature to improve overall wrist stability, especially on the ulnar side. These can be performed with a specialized hand grenade type device, or even simply a heavy stick, a broomstick, or an adjustable dumbbell with an uneven weight distribution, like a sledgehammer handle.
How do those work?
The key is to hold the device so that the heavier end is pointing away from the thumb towards the little finger side, and then practice motions that bring the pinky side of the wrist closer to the forearm. This is often called ulnar deviation, strengthening against resistance. This specific movement recruits and strengthens the muscles that pull the ulnar side of the wrist in, like ECU, extensor carpi ulnaris, which is often an area of relative weakness or atrophy in patients with chronic ulnar-sided wrist issues. Strengthening this can significantly improve stability and alleviate symptoms. Think of it as directly addressing the functional instability that arises from the underlying mechanical issues.
That's very targeted. Any other tips for rehab?
Patients can also experiment with different arm and hand positions during these strengthening exercises, such as performing them with the palm facing forward or backward, or the arm abducted away from the body. This engages the muscles from various angles and ensures comprehensive strengthening around the wrist and forearm. The frequency of these exercises is often dictated by the body's response, rather than rigid counting of repetitions. It's about continuing until the target muscles feel truly engaged and working, sometimes leading to a gentle fatigue, but never sharp pain.
Listening to the body.
Exactly. For chronic conditions, performing these exercises consistently, perhaps once in the morning and once at night, can lead to significant improvements in circulation, muscle health, and overall forearm and wrist well-being. Ultimately, it's about listening closely to one's body and tailoring the exercise regimen, ideally with physiotherapist guidance, to individual needs and symptoms. This often leads to profound improvements in comfort, function, and stability.
We've navigated the intricate world of ulnar-sided wrist pain today, from the fundamental biomechanics of the DRUJ to the distinct pathologies of ulnar impaction, HALT, this, and ulnar-styloid impaction syndromes, and explored their diagnostic pathways and nuanced treatment strategies. It's clear that a precise understanding, combined with targeted rehabilitation, is absolutely key to restoring function and relieving pain for our patients. This raises an important question. As our understanding evolves and technology advances, how might continued advancements in real-time imaging, perhaps artificial intelligence and diagnostics, and truly personalized biomaterials further refine our diagnostic precision and tailor patient-specific interventions for these often elusive risk conditions? Could we one day predict who is at risk before symptoms even begin? If you found this deep dive valuable, please consider rating and sharing it with colleagues who might also benefit from this discussion. My sincere thanks for joining me today and sharing such invaluable insights. Join us next time on The Deep Dive as we continue to explore the cutting edge of orthopedic knowledge. Goodbye for now.